We're going to talk about keeping patients at the quality, at the heart of everything we do. And very much so because as I'm getting older now, I'm realising that I'm going to be this patient soon, and I'm going to be really arsey and want people to do what I want them to do, and I want to make the decisions. So I think we need to now start looking at where we are with the patients. We already keep the patients in the middle of the decision-making process, but I think there's some facts and figures that may be quite useful in that in the next 5 years, we're losing 2/3 of our carers. So people that we rely on now to care for patients, be it informal carers, so those carers that aren't paid, so families, people that just go in and look after other people, they'll be gone. It costs at the moment £1.9 billion per year to pay for carers, which is more than the NHS itself costs to run. So when we lose these people that are caring for the patients, who's going to care for them? We've got no long-term facilities very much at the moment. Care homes are closing. People can't afford to go into care. And people don't particularly want to go into hospital. But what's going to happen? So we're going to end up having younger people caring. If those younger people caring, they're not working, so they're not paying taxes, they're not adding to the economy, and the economy continues to decrease. So we're in a bit of a circle at the moment of, well, what are we going to do for caring over the next 5 years? We also know that the ageing population is increasing, and we've got 1.1 million more people over the age of 85 than we had in 2007. So we've got a time bomb there waiting to happen. We've got lots of younger people, got lots of older people, but those people in the middle, we haven't got that many of. So we've got to look at quality. And we're all aware of the quality agenda that government implemented in 2008. Is everybody happy with that? Is anybody awake? Anybody listening? We had Department of Health, Darcy brought in the quality agenda and said that quality must be at the heart of everything we do. But more so, we've got to be able to measure quality. So we know that we give a quality care. You know you give the best care you can. But because everybody's so busy, we don't always document exactly what it is that you've done. To be able to give the proof to people that are auditing that actually this patient may have developed a pressure ulcer, but I did everything within my power to stop it, so it was unavoidable. We go to court, and courts will then say, well, if you've not written it down, it's never happened. But you know it happened. So we've got to get into the habit of writing everything down and finding that time to write things down so that we can prove that we are doing things. Department of Health in 2008 said that we need to look at patient safety, patient experience and the effectiveness of care. So when you're delivering care and you're thinking, well, I can't possibly document absolutely everything, these are 3 aspects that you need to be really aware of, and they're the things to be documenting. So how did you maintain patient safety? What was the patient experience? So when you talk to the patient, you talk to their family, you talk to their carers, document it. Let people know you have been communicating. And the effectiveness of care is, if you did 4-layer compression, if you gave a pressure redistributing mattress out, if you moved the patient every hour because you documented that their pressure areas were getting red, you must document that the implementation plan that you put in place is working. So don't just write down, we put a redistributing mattress in and we made the patient move every hour. You also need to document that. How did the patient feel and did it work? And was the patient involved in the decision-making process? So you didn't just go along and change mattresses. However, if we look at the news, we look at the media, unfortunately the NHS and health itself is getting quite a battering at the moment. You'll see good newspapers, Daily Mail, The Mirror, The Sun, The Star, The Telegraph, The Guardian, broadsheets, any sort of newspaper reporting nearly every day about the poor care that's going on in hospitals. And generally the poor care is attributed to the nursing staff. Very rarely to the occupational therapist or the physio, but it was the nursing staff. They'll say, my mother was shouting out and none of the nurses came along to give her a drink, or they didn't come and look after her pain, or I was looking for a nurse to help me move my mother. But there would have been OTs there as well, there would have been physios there would have been medical staff there, so why weren't those professionals asked as well? It's always the nursing staff, which is why we've got to document things and be very vocal about what we're doing as well, and tell people what a quality care it is that we're delivering. And again, ask the patient how they feel. Get the patient to say that I was involved in the decision-making process and I decided I didn't want to drink every hour, but I wanted to get a drink whenever my family came. But you must document it. However, we see these headlines as well, and again, nurses refuse to put 79-year-old Anne Robson on a drip. Well, one, would it be a nurse's decision sometimes to commence an intravenous infusion, or would it be the medical staff? It should have been the multidisciplinary team. It should have been their decision, everybody together with the patient in the middle or the family in the middle of that decision-making process. But because we don't always document everything that we do, then these headlines get into the papers and we've got nothing to say, well, actually, this is what we did do. Again, the Daily Mail earlier on this year talked about the amount of patients dying needlessly from bed sores, which is quite annoying because they're not called bed sores, they're called pressure ulcers, so they've got that wrong. And also, if you look at the audit figures that we've seen about avoidable and unavoidable pressure ulcers, we've seen a decrease in them as well. But people don't want to read about that. This is what sells newspapers. So if we're looking at quality of life, and we're also looking at putting the patient at the heart of everything we do, we've got to speak to that patient, we've got to communicate, and we've got to look at what quality is. So quality isn't just about getting that wound healed or getting that leg ulcer healed. Sometimes the healing of a wound or a leg ulcer isn't your final aim because you know it's never going to heal. But what your aims are and the quality are is that the patient is involved in the decision-making process, they're communicated to, mobility is enhanced, nutrition is enhanced, and pain is looked after. But similarly, lots of patients will say it's whether or not I can wear the clothes that I want to wear. So because I've got a leg ulcer and you're putting these huge bulky dressings on, I can't wear straight leg trousers, for example. And that ruins their quality of life. So we're looking at quality. This is why the patient has to be at the heart of everything we do. Ask them what they want to be the end point. Because sometimes what we want isn't always what the patient wants. And when we look at leg ulcers and we refer that to quality of life, we can see that there's a huge negative impact from having a leg ulcer. So mobility and functional needs tend to decrease. Levels of pain increase. Social functioning, people don't want to go out, you get social isolation, you get lots of exudate. You know what these problems are, and these are things that the patient wants to be looked after. So what can we do about all of this? And again, we have to keep the patient there at the heart and get them involved in decision making and make the patient take responsibility as well. Sometimes you go into a hospital ward and how many times are you there on a ward, patients come in, you start admitting, they say, when shall I put my pyjamas on? When shall I get into bed? And it's like you move over that threshold of the front door and suddenly you forget all common sense and you become the patient. Or more so when the patients will come to you and say, can I go to the toilet now, please? Well, yes, you can if you want. You don't have to ask. But you take on the patient mode. So we need the patient to take some responsibility as well. But we have to help educate and undertake health promotion. So Department of Health, the Labour government from a few years ago and the coalition government from recently have embarked on the quality agenda. So looking at quality, innovation, productivity and prevention. So we want to maintain quality through innovation, through increased productivity with no more resources than you have now, and prevention, so prevention of wound infections, pressure ulcers, chronic wounds. And on top of that, we have to save £20 billion by 2015, which is why we're seeing so many cuts as well. But sometimes the cuts are necessary to help us rethink how we're doing things. So we're looking at the patient, and you ask patients, what is it you want? What is a quality service for you, and how do you want to be involved? When we talk about a quality service, we'll say, well, the patient's warm, looked after, pain-free, fed, watered. When we've asked the patients, what they've actually said is important to them is cleanliness of the hospital. They want to be able to walk in and feel like they're not going to come out with an infection. If you look at the adverts about Bupa hospitals, have you seen them? That they'll then say, come to a Bupa hospital, it's clean. Which subliminally is telling you that an NHS hospital isn't clean. And this is what patients are worried about. They want the standard of the facilities as well. So they don't particularly want hospitals to look like hotels, but they want professional nurses and plenty of staff there as well, and people that will listen to their needs. But they also rely heavily on what others tell them. So somebody's gone into a hospital that they know and they say, it was really good, Ward 6 was excellent, the staff were lovely. Patients have said to us, well, that's where I want to go. If the next door neighbour says, I went in Ward 6 and it was awful, they never gave me a drink, they shouted at me, they were horrible, say, I never ever want to go into that hospital. So we are trying to give patient choice, and the government is trying to give patient choice as well. No more so than through the development of extending patient choice, which is any qualified provider. Everybody happy with that term? Put your hand up if you're not happy. Good. So we've got the any qualified provider out there, and this is so that clinicians can decide where they want to send their patients. So providers will look round, will have clinical commissioning groups who will be community trusts that will hold the purchasing powers. They'll decide where they want to buy these services from. So if you're looking at, for example, podiatry or leg ulcer services, they may say, well, we don't want to buy from the local trust. What we actually want to buy from is a social enterprise, or we want to buy from Ellie, for example. We've seen Ellie's leg club model. We think this works much better in the local trust, and that's where we want to send all our patients to. So you'll be able to give the patient the choice. So you can say to them when they come in to see the GP will say, I'm going to purchase from the leg club, so you can go there, or you can go to your local NHS trust. What they may also decide to do, clinical commissioning groups, is not buy anything from the NHS trust that's local and buy from elsewhere. And then patients will be said, this is where we're buying our services from. Similarly with patient choice and the quality agenda, what they've said as well, that patients can go in and see the GP and say where they want to be treated. So if you live in Yorkshire, you may go to your GP in Yorkshire and say, I've got this wound, but I've heard that Birmingham's really good at looking after wounds, and I want to be referred to Birmingham, and that's where I want my treatment. So patients have that choice. They can decide, and with the internet now being so easily accessible to many, they can start looking up on the internet to see what the quality indicators were for each trust, for their local trust, what the quality outcomes were, what infection rates are like, what pressure ulcer rates are like, and what healing of leg ulcers is like. And if they don't like that, or everything's too high, they can then decide to go somewhere else. So do we think choice will benefit the patient? I personally think it will, as long as we explain exactly what choice is and what choices patients can make. However, when we look at the evidence that's out there already, what people are saying is actually patients don't want the choice sometimes. They want to be told where's the best place to go. They trust professionals. They trust the GP, they trust the local surgeon to say, actually, Birmingham is really, really good for military wounds, and if you go there, you've got more chance of your wound being managed correctly. They then might say, but if you've got an orthopaedic wound, you need to go to a Royal National Orthopaedic Hospital in Stanmore. If you've got a pressure ulcer, you need to come to Yorkshire because they'll look after you. And patients tend to trust the professionals or word of mouth from friends. They don't particularly want to go in somewhere and say, well, I've got this infected wound, and the GP or the surgeon says, well, here's a list of different places you can go, you make your decision. They want people to help them. So we've got to ensure that we give patients choice, we enhance the quality of life, but we don't scare people as well. So what we need to do is look at how do we measure that quality, and I know Trudy's going to talk about measurement of quality after. But we need to look at, do patients receive a good quality clinical care? So what's the clinical effectiveness? Are patients safe? So look at rates of infection, rates of pressure ulcers, leg ulcer incidents, leg ulcer healing rates. Is it a clean, friendly environment? You go into hospital, you're scared, you're in pain and something's wrong. You want people to be nice to you. Similarly, you go home, community nurses come to see you. You want them to be friendly and to have time to talk to you as well. And the patient experience. And we're looking at different ways of getting the patient experience. Again, the government's been very clear that patients have to be at the heart of everything we do, but we have to listen to them and take them seriously. So we've got the National Patient Safety Campaign. We've got the commissioning pathways from the Department of Health, got Right Care and Safe Care, that has the safety thermometer on there, so each trust can measure their levels of safety. We've got the Never Events frameworks as well, that talks about each trust must record and publish their Never Events. Never Events are Category 3 and 4 pressure ulcers, DVTs, wrong site surgery, amongst others. We've also got how we're doing surveys. So patients that come into hospital are treated and are discharged home will receive a survey that says, how well did we do while you were in hospital? Was the ward clean? Were the nurses nice to you? Were the medical staff nice to you? Did you feel wanted? Did you feel valued? And were you included in your plan of care? So they want to know about that. All these documents are audited, and then each trust will get the feedback and they can see where they need to develop or where they're doing really well. We've got patient-reported outcome measures that I'm sure everybody is using, and they're beginning to come back in now and be audited, so we should have a couple of years of data very soon to be able to look at and see how well trusts are doing. The choice of provider, we now have 25 different any qualified providers across the country in different services. So you look at children's services, wheelchair services, leg ulcer, wound care, podiatry. So you're going to see many more any qualified providers appearing in areas that you work. And there's local initiatives that local people are doing to improve quality and to keep the patient there as the focus. We've also got the 15 Steps Challenge, which was produced by the Productive stream from the Department of Health. And this is to help staff, patients and others work together so we can get improvements and develop patient care and the patient experience. But also staff and patients are working together. It can help professionals develop as well. Remember, it's got to be two-way. If patients and relatives don't tell us where we're going wrong, we don't know how to change it. So it's got to be two-way. 15-step challenge as well provides a way of understanding patients' first impressions more clearly. And it's a method of creating positive improvements. And remember, the whole thing about quality and keeping the patient at the heart of everything is that it's constructive and not destructive. So that everything we talk about and do will help improve patient care in the future. So we can't make choices without involving patients, otherwise not very pleasant things happen. But we can also look at decision-making trees. So if people are still struggling a little bit and thinking, well, we do things in our place of work, or actually there's some areas we may develop, but how do I get the patient to be involved? Do patients want to be involved? There's lots of public patient groups around the whole country where you can join in with those and get those people to come and see you and talk to you about how well they've developed groups. The Leg Club is a fantastic example of public patient involvement. So talk to people involved in the Leg Club about, well, how did you make a change to the things that you were doing within leg clubs, within leg ulcers? How do you get the patient involved? And even though we keep saying we must keep the patient at the centre, patients are sometimes a little bit worried about why we're suddenly asking them questions. So it's to make them feel wanted and welcome. And then there's trees such as this that talks about how you can actually have a full model that's an academic model for looking at patient quality. And again, this is looking at research and evidence that people have already undertaken and then breaking that research and evidence down to understand it for you and the patient, but to help develop guidance, policies and protocols. So, to conclude really, ensure that your patient receives the correct care by keeping them involved at all times. And just on a happy note really, that the RCN and the King's Fund undertook a huge survey last year about how positive patients were feeling with the care that they received. And what came out of this survey of over 700,000 people was that 92% of patients said they got good or excellent care while they're in hospital. So that's really good. If you look at the media stories, it looks like it's the other way around. It's 8% of people didn't get good care and 92% got poor care. But 92% of people were happy. So we've got 8% still to go to ensure that they're happy and involved in everything we do. Thank you for listening, and I'm very warm in here.